Spiegelman. I just lost my screen. I'm Donna Spiegelman. I'm the Susan Dwight Bliss Professor of Biostatistics in the Department of Biostatistics at the Yale School of Public Health. I'm director of our Center for Methods and Implementation and Prevention Science, a co-sponsor of this webinar. CMIPS, as we call ourselves, develops and disseminates innovative quantitative, qualitative, and health economics methods to advance implementation and prevention science. If you'd like to join our listserv to learn more about our activities and events, please email me through the chat or by email. We'd be happy to welcome you as part of our community. This talk is co-sponsored by Yale's Center for Interdisciplinary Research on AIDS, otherwise known as CIRA, in which our Ready Hub, which I'll tell you about in a second, is embedded as a supplement. CIRA was established in 1997 and is currently New England's only National Institute of Mental Health's funded AIDS research center. CIRA supports innovative interdisciplinary research that focuses on the implementation of HIV prevention and treatment strategies and the elimination of HIV disparities. This talk is additionally co-sponsored by the Implementation the Implementation Science Coordination, Consultation, and Collaboration Initiative, otherwise known as ISCI. This community of practice leads the efforts of 35 projects around the United States, supported by the US government, aimed at ending the HIV epidemic, along with 6 technical support hubs, of which our hub is one. That is our Ready Hub. And I direct this hub, the Ready Hub, the rigorous, rapid, and relevant evidence adaptation and implementation to ending the HIV epidemic technical support hub. We provide technical support to in quantitative, qualitative, and health economics methods to the 35 End the AIDS Epidemic projects around the country and hands-on support to 7 of these projects. Today's talk arose from our work with one of these projects entitled Clinical Decision Support for PrEP, that's led by Drs. David Hicks, the Deputy Health Officer of the Jefferson County Department of Public Health in Alabama, Julia Marcus, Associate Professor in the Department of Population Medicine, and Douglas Krakauer, Assistant Professor in Medicine and Population Medicine, both from the Harvard Medical School. We are delighted that Dr. Hicks and his team at the Jefferson County, Alabama Department of Public Health suggested that we develop and present today's talk of great relevance to their project, which uses machine learning methods to develop a model to identify patients at high risk for HIV infection in their system to subsequently initiate PrEP. I'm pleased to introduce today's speaker, Professor Zhou, Assistant Professor in the Department of Biostatistics. Our Ready Hub consists of 4 lead technical team members, each of whom is assigned to provide hands-on support to one of our 7 primary projects. In addition, our Ready Hub consists of over a dozen additional team members with expertise in a wide range of potential methodologic areas that we had anticipated could arise as we support our projects. Zhou, one of these Ready Hub team members, is an expert in machine learning and risk prediction. Before I turn over the mic to him, I'd like to thank one of our other core Ready Hub experts, Dr. Christine Simon, who worked closely with Dr. Zhou to ensure that this technical talk would be of maximum use to you all, our audience. Chris, if you'd like to wave hello to our listeners, that would be great. And right now, I'd like to turn the virtual mic over to Xin to present his talk on risk prediction modeling, a machine learning approach to ending the HIV epidemic.
Oh, okay. Thanks, Donna, for the introduction. In this talk, I will introduce the basic concepts and machine learning approaches for risk prediction modeling with application to HIV studies. This is the outline of this talk. I will start with definitions and then use a toy example to illustrate the idea of using supervised learning for risk prediction. Then I'll briefly introduce several often used machine learning approaches. Then I'll introduce the cross-validation for evaluating risk prediction models. I will focus on variable selection, since in the HIV studies, there are many covariates, and the variable selection is very important to get a reliable model. Finally, I will present a published HIV study as an example. Okay, in machine learning, there are two main learning tasks: the supervised learning and the unsupervised learning. The supervised learning is to yield the desired output that can be used for mapping from observed covariates. In other words, the supervised learning want to find the relationship between covariates and outcome. Well, for the unsupervised learning, we only observe the covariates and want to find the intrinsic relationship within covariates. There are two different types of supervised learning: regression and classification. When the outcome is continuous, this is a regression problem. When the outcome is discrete, like HIV versus non-HIV, it's a classification problem. Classification is a process of predicting the class of given subjects. Risk prediction model is to estimate the risk of an individual developing future health outcomes based on covariates or predictors. Let's take a look at this toy example. I made up this data example for illustration purpose. As shown in the plot on the left, this example is to distinguish between incident HIV and non-HIV within 1 year. Or in other words, we want to predict who is at highest risk of HIV infection in the next year. And there are only two covariates. The first one, X1, the number of sexual partners, and X2 is the HIV infection rate in the community. Besides the covariates, we also have the health outcome, incident HIV in the next year. In the plot, the incident HIV cases are marked in red, and non-HIV subjects are in black. This is a standard supervised learning. Since the outcome is binary, or in other words, the outcome is discrete, this is a classification problem. In the real study, the number of covariates are usually in tens or hundreds. But in this toy example, we only consider two, since we can graphically show the data in a plot. The task is to distinguish between HIV and non-HIV only using the covariates. In other words, we want to separate the covariate space into two non-overlapping parts. One is classified to HIV cases, and the other is non-HIV. The simplest classifier is a linear classifier, as shown in the plot. This line is called the decision boundary, and it's a linear combination of the two covariates. The left part would be predicted as the non-HIV, and the right part for the HIV. we can see that there are several red points. There are several red points here, and also some black points. There are some red points on the left part, and also some black points on the right part. They are misclassified. Here, we only consider the output is binary. This is called hard classification. For hard classification, for example, here, there are 3 points, A, B, and C. A is classified as non-HIV, and B and C are both classified as HIV. But actually, we have no idea about the difference between B and C, and we don't know which one is risky for the disease. Alternatively, soft classification outputs the probability for each health outcome. For example, here, for subject B, the probability of HIV is 90%, and for subject C, the probability of HIV is maybe about 65%. So B is riskier than C. Soft classification is very useful for risk prediction modeling. There exists some non-linear classification method. For example, the classifier on the left is highly non-linear and very complicated. It classifies all the subjects in the dataset correctly. Is it a good classifier? Actually, I don't think so. Consider a new data point marked in green here. Marked in green here. And the classifier predicts this point as HIV case, but I think it's probably non-HIV. The classifier on the right is another non-linear classifier, but less complicated than the one on the left. Okay, there are many classification methods proposed in the literature. Actually, this is a whole semester-long course for classification method. In this talk, I only briefly introduce some of them. The first one is logistic regression. It has been well investigated in statistics. It's designed to output the probability of health outcome. This is a soft classification method. The second is random forest. It's a non-parametric method, and a random forest is a collection of classification trees and combined output from all these trees. The support vector machine was quite popular about a decade ago. It has a nice theoretical property, but the computation is high, especially when the sample size is large. Now it's almost replaced with deep learning. Deep learning was developed from a neural network, and its computation is also very high. The logistic regression and random forest can be seen as a soft classification method. Although support vector machine and neural network do not output the probability of health outcomes, there exist some measures to approximate these probabilities. So they can also use in risk prediction modeling. Superlinear is an ensemble machine learning algorithm that combines all the classification methods and models that you might investigate for a risk prediction modeling problem, and then use them to make a prediction. Use all the model to make a prediction that may be as good as or even better than any single model that you may have investigated. Okay. Okay, now we move to the performance evaluation. Let's go back to the toy example, and we have 3 classifiers. One is linear, and 2 are non-linear. The natural question is, which one is the best? We need some evaluation. Criterion to assess the performance of the classification. An easy one is the training accuracy. We generate a classifier on a data set, and then we evaluate the performance of this classifier on the same data set. Based on the training accuracy, the second one is the best. But just as this one, the second one, is the best. But just I explained before, actually, I don't agree with it. So to get a good evaluation criterion, we need to think about the purpose of supervised learning. Actually, the purpose of supervised learning is not to classify all the data points or all the subjects in the data set correctly. Actually, it's to classify new data points. That is, we want to classify the new data points as correctly as possible. The new data points means is not included in the data set to generate the classifier. The classification accuracy of new data points is called generalization. That's what we want. Okay, the data used to generate a classifier is called the training set. And the data used to evaluate the performance of classifiers is called a test set. For the training accuracy, the training set and the test set are the same. This is a problem. So the evaluation is optimistic. We need to separate the training set and the test set. The ideal situation is that we have 2 independent studies. That one is used as the training set, and the other is used as a test set. But the problem is that in practice, we usually have only one data set, even though sometimes we have 2 independent studies. We would like to combine them together to get a more reliable or more accurate classification. So suppose a case when we only have one data set, the holdout cross-validation is one way to evaluate the classification model. The holdout validation randomly separates this data set into 2 parts. The one is used as the training set, and the other one uses the test set. For example, the training set may be 2/3 of the whole data set, and the test set is the rest 1/3. The holdout validation is often used when the sample size is huge. This validation relies on the splitting of the dataset. And for a small dataset, the evaluation is often with high variance and is not very reliable. And in practice, the cross-validation is widely used. The figure here shows the procedure of tenfold cross-validation. For tenfold cross-validation, we first randomly separate the dataset into 10 parts, and then on the first step, we use the first part as a test set, and then combine the rest 9 parts as the training set. We generate the classifier on the training set, and then test the performance of this generated classifier on the test set. Then on step 2, we use the second part as a test set, and then similarly use the rest 9 parts as the training set. Then we repeat the procedure of generate the classifier and then test the classifier on the test set. Then we get the second part evaluated. Repeat the procedure 10 times. We have all the 10 parts evaluated. And the final cross-validation result is just the average of these 10 results on 10 separate parts. Then in practice, the K is usually chosen as 5 and 5 or 10. When the sample size is kind of large, we usually use K is 5, and when the sample size is maybe kind of small, and we may use we may use K as 10. Okay, the previous slides I introduced the evaluation procedure, and we prefer the cross-validation. And for evaluation criterion, in the computer science community, the classification error rate is often used. It's just a probability of misclassification. In the statistics community, we often use some information criterion like AIC or BIC, and also AUC, that is area under curve, is also often used in statistics community. And this criterion also called C statistic. AUC is area under the ROC curve. ROC just so in this figure, ROC is a plot of true positive rate and a false positive rate when the classification thresholds varies. True positive rate is the probability of a correct classification among actual positives. It's just sensitivity. And the false positive rate is the probability of misclassification among actual negatives, and is 1 minus specificity. In practice, we often use 50% as the classification threshold. That is, if the risk or probability of HIV is greater than 50%, we predict this subject as HIV And this way, we may also use maybe a 40%, 70%, 90% as a threshold. And for each threshold, we have a pair of true positive rates and the false positive rate. We vary the threshold, and then we have this ROC plot. And there's two extreme cases, that this one and this one, corresponding to the threshold of 0% and 100%. So that is, we predict all the subjects to HIV cases, or we predict all the subjects to non-HIV cases, respectively. And when we have the ROC curve, the AUC is the area under the ROC curve, and it's number between 0 and 1, and it's better when AUC is close to 1. Okay, let's move to the variable selection. As I mentioned before, when the number of covariates is large in real application, and the variable selection is very important. There are two different groups of variable selection methods. One is kind of the general approach that can apply to any classification method. And the second is classification specific approach. The iterative approach is a general method. We can carry out the search forward, backward, or stepwise. The shrinkage method is in the second group, and is usually combined with linear classification method. For example, logistics regression. And lasso, that is least absolute shrinkage and selection operator, is often used shrinkage method in practice. And there's some also there's some also lasso variants, like the adaptive lasso and the group lasso. And in the literature, there are also some non-convex penalty can use for shrinkage method, and like the MCP and the SCAD. Okay, first for the iterative approach, forward search. And suppose the number of variables is 5, like so in the figure. The forward search starts from an empty covariate set, and on the first step, consider all possible covariate sites with only one covariate. So there are 5 candidate variable sets. The first one is only have x1, and the second one only have x2, and so on. Then we use some cross-validation method to evaluate the performance of the model from each candidate variable set, and then choose the best one. And suppose in this case the best one is x2, and then on the second step, we keep x2 in the candidate variable set, and adding other covariates to generate the candidate variable set with only 2 covariates, and then compare. So at this step, on this step, we have 4 candidate covariate set, and we compare these 4 and choose the best one of them. and repeat the procedure until no improvement when adding one or more covariates. That is the forward selection. Next one is backward elimination, and it's different with the forward selection. The procedure starts from all covariates. That is, start from the full model, and on the first step, we temporarily remove one covariate from the full model. Then we generate 5 candidate covariate sets, and then we compare these 5 candidate covariate sets and choose and get the best one from them. And suppose the best among these 5 is this covariate set that is contains x1, x2, x3, and x5. Then starting from this covariate sets on the next step, we further remove one of them. So on the second step, we have 4 candidate covariate sets. Then we compare these 4 and choose best covariate set. And for this case, there may be x2, x3, and x5. Then repeat the procedure until no improvement when discarding one or more covariates. That is a backward elimination. And my opinion that when the number of covariates not very huge, the backward elimination is kind of better than forward selection. And the next one is a stepwise selection that combines the forward selection and the backward elimination. It starts from empty site. Then first we do forward selection to choose one best covariate into the covariate set, and then we run the backward elimination to discuss one if evaluation criterion is improved. Then repeat the forward and backward until no improvement on the criterion. Any questions so far?
Yes, Shin, we did get an interesting question from Dr. Hicks. He asked, with the iterative approach, can you discern which covariate is more predictive than another? And actually, Shin, this was a similar question to what Alexandra had. We were working on a similar project with other investigators. And so, Shin, he's asking about can we interpret the coefficients of covariates in the model, or at least say whether a certain covariate is more important for prediction than another when we use these iterative approaches?
Yeah, that's a good question. And actually for iterative approach, for example, for forward selection, we generally think that the one selected at the beginning should be more important than the one selected maybe later. And for the backward elimination, we think that the first one, the first several covariates discarded from the variable set may be not important. But it's just kind of, I think, not that guarantee, since the iterative method is just some suboptimal method. So it just kind of, yeah, that is some kind of, we cannot, actually for this kind of method, we cannot get the important, very important individual variable, since this procedure focuses on the variable covariate size. That the advantage of this method is that it considers the correlation within covariates. and this may help to improve the prediction performance.
Dr. Hitz, did that answer your question?
Yes, thank you.
Okay. Now we move to another group of variable selection approach is shrinkage. Lasso is a widely used shrinkage method. It falls into the regularization framework, which minimize the sum of a loss function and a penalty function. The loss function describes the fitting of training data, that is training accuracy, and the penalty describes the complexity of the model. And for the loss function, if the outcome is continuous, and the least square loss is often used, and when the outcome is binary, the logistic loss is often used. As I mentioned before, a complicated model would work quite well on the training side, but may not perform well on the test side. So we expect to find a simple model to work reasonably well on the training side. For lasso, this one is the loss function, and it describes the training accuracy, and this one is the lasso penalty, and used for describe the complexity of the model. And lambda here is a tuning parameter. And lambda is used to balance the trade-off between the training accuracy and model complexity. We can use cross-validation. And this figure shows, this figure explains how lasso perform variable selection. It's a very smart idea. The original lasso optimization problem can be viewed as a least equivalent form. That is minimize the loss function, but penalty subject to the lasso penalty upper bounded by a constant s. And here s has the same here the s here is just like the lambda, can be used to balance these two, just balance the loss function and the lasso penalty. And this string can be seen as this blue square. And here the right red one is just the contour. So that means the loss function increase from this way. Now the lasso solution is the first place that the loss function contours touch the square. Yeah, since the loss function increase when the beta move in this way, and when the contour touch the square, it sometimes sometimes occurs at a corner like here. Which means we only select x2 and remove X1. So that's the reason why lasso can perform variable selection. Okay, let's move to the case study. I have some experience in risk prediction on cancer study and also on social science studies, but have little experience in HIV study. So I use a published HIV study as a data example. This study was just published in Statistics in Medicine by Susan Gruber, etc. And it's to use electronic health records to identify candidates for HIV pre-exposure prophylaxis test. The data were from electronic health records between 2007 and 2015 at Atris Health. There are about 400,000 patients, and there were 150 new incident HIV cases. There were 180 risk factors extracted from the electronic health records, including demographic, diagnosis, treatment, and prescriptions. The outcome is a 1-year risk of acquiring HIV. There were 180 queries. Among them, 46 were dropped due to lack of variation or due to collinearity. So these 46 queries would provide almost no additional predictive ability. So the analytic data sets contains 134 queries. And X0 is the baseline demographics, and X2 to T are medical information during past 1 year and the past 2 years. And ZT is ZT summarize medical history that may contain some information 2 years ago.
William, are you there? I think we
yes, I am. Did we lose Shen?
Shen?
It looks like we did.
Okay, hang on, everybody. We'll see what we can do. I'll send him a text message. Sorry about that.
The number you dialed is not a working number. Please check the number and dial again.
Oh, no.
Yeah, sorry, I'm. Hello?
Yeah, hi, Shen.
Shen, we can hear you.
But we don't see your screen now.
Okay, sorry, I think maybe my network, something wrong with my network. Okay, I will check.
Well, we're all here patiently waiting. Yep, okay. Well, now we see your email. And I'll tell you, okay, there we go. You might have been on the previous slide where you were talking about all the different covariates. Yeah, No, not
Okay.
there. Here, I think we left off there. Yeah. Thank you,
Okay.
Shin.
Okay. Okay. There were 180 queries. Among them, 46 were dropped due to lack of variation or due to collinearity, and these 46 queries could provide almost no additional predictive power. And the analytics dataset contains 134 queries, and X0 is the baseline demographics, and X tilde T are medical information during past 1 year and the past 2 years. And ZT is ZT summarizes the medical information, summarize the medical history, and they may these queries may contain the information 2 years ago. Just the different with X tilde T. And there were also 23 pre-selected risk factors identified by experts, and they are potential strong predictors among the 134 queries. We want each classification method develop a method based on all queries, and also based on expert selected subset of queries. The number of HIV cases is very small compared with the huge number of controls. The original data set was highly unbalanced since the HIV prevalence is rare. And this unbalanced case and control presents a challenge problem for machine learning approaches. So in the analytic data set, the ratio of case to controls were sort of balanced by using sampling schemes. And the controls in the analytic data sets were randomly selected according to the ratio of 1 cases versus 50 controls, stratified by gender. And the sample size of the analytic data is about 7,600. Okay, this list shows the variant machine learning models considered in the super learner. And now for some, we consider the logistic regression, lasso, and also random forest, support vector machine, and neural network. We briefly described those methods before, but here for the ridge regression, it's very similar to the lasso, but the method is similar to lasso. For lasso, use L1 penalty, but for the ridge regression, use L2 penalty. But since use L2 penalty, the ridge regression cannot perform the variable selection. And now, in the candidate models, we also consider different ratio of case to control. Then we also consider 1 case versus 20 controls, or 1 case versus 10 controls. And also we consider the model on all query set, and also on pre-selected query sets. And in total, there are 42 machine learning models used in the superlearner. And this slide shows the results for these 42 machine learning models, and also consider the super learner. That's the model combine all the other models together. And the lasso, this one, the lasso with the ratio of one case versus 20 controls, all perform other models. And the cross-validated AUC is about 0.86. And the superlearner yield cross-validated AUC at 0.84. This one, 0.84. So the conclusion is that the machine learning machine learning was successful at developing a model to predict the 1 year risk of acquiring HIV based on the data from electronic health records. Okay, that's what I have for today's talk. Now I'm ready to take questions.
Thank you, Shin. So that is perfect timing. And we did get a question in the chat about, thank you for giving this a lucid overview of machine learning algorithms. I observed that nothing was said about reinforcement learning. Can you share how reinforcement learning can be applied to HIV research? So first of all, Shin, do you know what reinforcement learning is? And can you say briefly to our audience what it is?
Oh, yeah. Reinforcement is kind of different learning tasks with the supervised learning and unsupervised learning I introduced today. Reinforcement is just kind of yeah, reinforcement often used currently in statistics used in precision medicine. For example, there's 2 treatments, and we want to know which treatment is best. And that for this case, for this case, we need to know the performance for each treatment. And then we may just use the trial and error technique just in reinforcement learning. And we may just, for a given subject, we may try one treatment and get a performance, and we may try another treatment, get a kind of different measurement score, and then compare these 2 scores, and then we know which treatment is best for the subject with this characteristic. Yeah, but since the reinforcement saw kind of different machine learning tasks, it may not apply to the risk prediction modeling, but the reinforcement is quite further maybe working to predict which treatment is best. Just at the setting of precision medicine.
Did that answer your question? Did that answer your question, Daniel? If you're still with us. Oh, I don't know if people can even hear me. Am I on mute? No. Okay, well, Daniel.
The question was answered in the chat. And there's another question in the chat as well.
Yes.
Okay.
So the next question is, for number of partners, do you consider the HIV status of each partner? So I can maybe take that question. When these kinds of prediction algorithms are developed, like say, for example, to identify patients coming into clinics that are at highest risk for HIV infection, you kind of have to use the variables that are available in the system. And usually this wouldn't be research grade data, it would be administratively collected data in the system. So I might guess that in the system, we'd be lucky if for each patient it was even recorded their number of partners. And probably less likely that the HIV status of each partner would be available. But if all of those were, there would be different ways of coding the variables as candidate variables in the selection set, and that could be number of partners, proportion HIV infected, or number of partners infected, number of uninfected partners. But I don't know, David Hicks and Julia Marcus, if, say, in our particular case, would those kinds of variables be available in the system as even candidate variables?
Well, I would say that type of data isn't a completely separate database for our project. That's in our traditional public health epidemiology database, but that's not coming, generally speaking, out of our EHR system unless someone else on the call knows that. So that might be shoddy as far as the yield of what we can get out of the EHR, but it potentially in the future could be pulled out of another database that we have.
Yeah, so I don't know, Julia or others, do you have anything to add? I mean, my impression is, routine electronic medical records, we wouldn't have detailed information about sort of these sorts of HIV risk factors, and we have to make do with what's in there.
Yeah, that's right. I mean, I think there's a push to do better data collection on things like gender of sex partners and whether somebody's sexually active and gender identity and all of those factors that may help with HIV risk prediction. So I think it's improving over time. But yeah, we're not going to have, in general, unless we're talking about a sexual health clinic, we're not going to have EHR data on number of partners, HIV status of partners, et cetera. But you can still predict HIV risk with bringing in a lot of other variables in the EHR, especially ones that are proxies for, network level risk, like where a patient lives, if they're in a high incidence neighborhood, that kind of thing. So you can kind of make up for the absence of some of those individual level factors with other kinds of factors you can pull in.
Yeah. Yeah, so maybe we are a little over time, but we did have a little gap because of the network issues. So maybe our last question from Daniel is, there are many kinds of neural network algorithms. And Shin, I don't know if you could comment on to what extent that's true and what neural network approach would be recommended. And I don't know if in the work that's been done already by the group of Julia Marcus and David Hicks, if neural networks were part of the algorithms chosen. I think you all used a super learner, so maybe it had at least one neural network in there. But maybe first, Shin, you could say something about are there many kinds of neural network algorithms, and is there anything known about their relative performance to each other?
Oh yes, I agree. There are many types of neural networks algorithm in literature, and in the work I present, the author used feed-forward neural nets, and but actually, from my opinion, since the neural network is kind of old, and now almost all the people move to a deep learning, and the major disadvantage of neural network is it's easy for overfitting. So especially when the number of queries is large, and the performance of neural network may not comparable with other machine learning methods.
Thanks, Shannon. Sort of in the interest of time, I think we have to wrap up. If there's people on this call from the ISKI collaborative projects and hubs who are interested in pursuing some of these approaches, please don't hesitate to be in touch with us. And a big thanks to Shin and Chris Simon and our colleagues David Hicks and Julia Marcus for initiating this. So thank you all and have a good evening. Bye-bye.
Okay, bye.
Thank you so much.